Hello, everybody. My name is Mikkel Norholm. I am the Director of Product Development and Head of European Operations with Exosome Diagnostics. Welcome to this webinar presentation with Dr. Kretschmar, which is entitled Beyond PSA, Urine Gene Expression Assay for Early Risk Assessment of Prostate Cancer. We're very pleased to have you all join us. It's my great pleasure to introduce today's speaker, Dr. Kretschmar, who is an assistant professor of urology in the Department of Urology at the Ludwig-Maximilians University in Munich, Germany. Dr. Kretschmar completed his medical training with an internship in Zurich and Hong Kong and a postdoc fellowship at the Vancouver Prostate Center. And at the Ludwig-Maximilians University, he is acting head of the prostate cancer clinic, and he was the principal investigator on the EPCE European validation study, which we're currently writing up for publication. Please note that during the presentation, all participants will be in listen-only mode, but if you enter your questions in the chat box at the bottom of the page or of the screen, we'll be happy to address them after the presentation. And with that, I'd like to hand it over to Dr. Kretschmar.
Thank you, Mikkel, for the kind introduction, and thank you so much for having me for today's webinar, which is called Beyond PSA, Utility of a Urine Gene Expression Assay for Early Risk Assessment of Prostate Cancer. So here are my disclosures, and here you see the learning objectives. After completing the webinar, you will be able to understand the basics of exosomes and exosome-based diagnostic tools. You will learn why an exosome-based liquid biomarker approach offers an ideal platform for the early risk assessment of high-grade prostate cancer. You will understand the performance of various biomarkers and how they fit into clinical practice. And finally, you will be able to determine which patients would most benefit from the ExoDx prostate test as a risk assessment tool. So why are we even talking about this? You all are aware of the dilemma of PSA screening, because on one hand, prostate cancer is a global killer. We are all aware of that. And here are current data from the US. You see that prostate cancer is ranked #1 at the estimated new cases in the US and ranked #2 in the estimated deaths in the United States. So it's very, very relevant what we are talking about. And on the other hand, PSA screening that we know nowadays is a success story. This is a very, very interesting graph showing that based on the initiation of widespread PSA screening, we saw a massive decline in metastatic disease, in the incidence of metastatic disease. And you also see that the initiation of widespread mammography screening didn't cause those effects. So why are we not happy with the PSA screening as it is right now? This is because of the cost that might come with the PSA screening in its current form. And we all know that we have the dilemma of overdiagnosis and overtreatment. And this is basically based on the fact that we are not able to distinguish respective sub-entities of prostate cancer. Because when you look at this slide, so we have tumor C and tumor B. They are both diagnosed in the localized stage, but tumor B, which is called the turtle, is progressing very, very slowly and will probably never reach metastatic stage. However, tumor C, which is called the rabbit, is going to spread very, very fast and will reach metastatic stages in a very, very short period. So how do we distinguish those two tumors? And we don't have the holy grail right now available yet. However, one step into the correct direction is the implementation of risk scores. So risk scores that are usually multifactorial and have a lot of clinical factors implemented, they are used for risk stratification. And by implementing them, we're doing actually a better job than we did before. Here you see the results of the usage of the CAPRA score, which is one of the nowadays available risk scores. And you will see that based on the timeline and based on the risk score stratification, active surveillance is actually increasing nowadays. You see 40% right now as opposed to, let's see, 14% and 20 years ago. So we're doing a better job, but is it actually enough? And this is a well-known problem for many years now. Almost 10 years ago, we were talking about exactly the same things in a very, very highly appreciated journals. So that is always a point, and it's a very, very political topic. PSA screening is something everyone has an opinion about, and also very political organizations like the EU Commission, they are going to give their recommendations, as well as national agencies. And current evidence is currently based on the latest meta-analysis, which has been published in 2018, and it showed that PSA screening indeed increases the incidence of localized prostate cancer. However, it did not decrease all-cause mortality, as well as prostate cancer-specific mortality. So kind of a two-sided sword, and that is what we have to deal with right now. So what do the European guidelines say? They refer to those problems by recommending, with a strong recommendation, to not subject men to PSA testing without counseling them on the potential risks and benefits. So let's also talk about the elephant in the room. Let's not forget the MRI that has been used in a very widespread manner recently. And we have data from large trials that have showed that if we use a standardized assessment of the MP-MRI findings, we can do actually a pretty good job by determining the risk of clinically significant prostate cancer. It has been shown that with the implementation of the so-called PIRATES score that you're all aware of, the incidence of clinically significant prostate cancer actually increases with higher PIRATES scores. However, the MP-MRI is not a holy grail as well. We do know about problems regarding inter-observer variability and consecutive information loss. And it has been shown that, for instance, for less experienced radiologists, there is a tendency towards PIRATES 3, for instance. So this is something that we have to be aware of. So prostate cancer screening in 2021, where do we stand right now? What is the current state of the art? And there has been a very, very recent publication that has been published just several months ago by the EAU, and they implemented current recommendations regarding early detection of prostate cancer, as well as prostate cancer screening. And what they introduced was something that they called Screening 2.0. And Screening 2.0 was part of a multifactorial screening assessment. First of all, PSA screening should be age dependent. And based on the age of the respective patients, there should be separate PSA cutoff values. So do not use just one PSA cutoff value, use it with regards of the respective patient age. And if you use risk stratification based on the risk calculators that are available nowadays, patients are separated between low risk and high risk patients, and high risk patients should receive an MRI, and based on the MRI, go on with further risk stratification or go on with prostate biopsy. So this is the first recommendation, official recommendation, that implements MRI at a very early stage. So how can molecular biomarkers help to introduce smarter screening, smarter than we used to do it in the recent years? And to answer this issue, we have to determine what kind of biomarkers do we actually have. So we have to distinguish between diagnostic biomarkers and prognostic biomarkers. While diagnostic biomarkers tackle the questions who to biopsy or when to rebiopsy, prognostic biomarkers are addressing the clinical issue who to treat. And here on the slides, you see a completely arbitrary risk of several biomarkers that are currently available. And based on today's webinar, we're of course talking a little bit more about the EPI test. We cannot talk about the EPI test without knowing what exosomes actually are. Exosomes are a very recently discovered new mode of cellular communication. As opposed to endocrine, paracrine, neuronal, or contact-dependent communication, exosomes are part of the vesicle-mediated communication system of the cells. They are very, very small, just up to 100 nanometers, so significantly smaller compared to bacteria, platelets, or even cells. But they are very attractive from a diagnostic point of view because they are released by normal as well as cancerous cells. They are basically released by all living cells into biofluids. They play a role in health and disease, and they can deliver molecules that are not normally secreted from cells. So they are opposed to just standard secretion by cells. And that's why they have been termed something like a treasure trove of RNA, DNA, and protein, something like a cellular tweet, because they are released by thousands per cell from all living cells in normal cells, as well as in early and late disease stages. So that makes them ideal for early detection of prostate cancer. They do play a role in cellular communication, immune system inhibition, and they stimulate tumor growth. They contain RNA, DNA, and protein, as previously mentioned. So those markers allow the secreting cell to be identified. And as previously mentioned as well, they can be collected from any biofluid. So exosome diagnostic enables the earlier detection of disease and as well the longitudinal tracking of several biomarkers. They do provide real-time data, something like biological snapshots, if you want to call it that way, about what drives the individual patient's condition and response to therapy. They are usually non-invasive, or at least minimally invasive. They overcome tissue heterogeneity concerns, and they do also overcome the signal noise challenges that are faced by other approaches such as CTCs or cell-free DNA. And they do allow full transcriptome profiling that matches tissue samples. So let's talk a little bit more about the ExoDX prostate test. The ExoDX test may be utilized for men that are older or 50 years or older with a PSA value of 2 to 10 that are being considered for prostate biopsy. The ExoDX prostate test assesses a patient's risk for high-grade prostate cancer, which has been defined as a Gleason score, a combined Gleason score of 7 or more. It is a non-invasive urine-based assay, and this is very suitable for easy in-office collection. As opposed to some other biomarker tests, here there is no DRE or no prostate massage required, which makes it even more easy to perform. And it also has recently been included in the current NCCN guidelines for early detection of prostate cancer in initial as well as repeat biopsy. So, how is the workflow? First, of course, the patient has to collect or have to give a urine sample. Usually 15 milliliters of first catch urine are enough. Then the urine sample is shipped to the respective laboratory, and the patented exosomal RNA extraction is performed. Then, after the RNA extraction, the EPI testing based on a multivariate algorithmic analysis and a QRT-PCR analysis is performed. And finally, a risk score for high-grade prostate cancer is generated, and a standardized form sheet is being sent back to the referring physician, giving a recommendation, or let's say an interpretation of the EPI test. So the EPI test is not binary per se. The test score ranges from 0 to 100 and is separate from standard of care factors to help assess a patient's risk for high-grade prostate cancer. The EPI test, as earlier mentioned, is only used when considering initial or repeat biopsy. And the EPI-CE test that has recently been introduced has a sensitivity of 92% and a negative predictive value of 89% regarding high-grade prostate cancer. So here it has to be mentioned that the EPI-CE test is based on the well-established ExoDx prostate test that has successfully been operated from ExoDx CLIA facility in the US since 2016 and is currently reimbursed by several leading insurance providers. Both tests share the same specimen requirements, the same exoRNA isolation methodology, the same qPCR detection of the biomarkers, and the same algorithm for risk score calculation. However, the EPI-CE test has been further developed for distribution and use in third-party clinical laboratories in the EU and comprises a ready-to-use CE-IVD assay reagent kit and also cloud-based CE-IVD software to facilitate the risk score calculation. So based on the algorithm, a cut point is generated, a cut point of 15.6. If the patient is below this cut point, the patient has a decreased likelihood of high-grade prostate cancer. On the other hand, if the patient is above the cut point, he has an increased likelihood of high-grade prostate cancer, again defined as a Gleason score of 7 or more. So this is an image of an official test report that you are going to receive once you ordered the EPI test. And as I mentioned earlier, it contains, of course, patient information, client information, and the specimen information, and the EPI IntelliScore. So in this case, it's 9.3, and you realize it's below the cut point. But on the sheet, you also get an assay interpretation, so additional comments. You don't have to know the cut point by heart. You are going to receive some explanations. So it has been shown, and I'm going to show you later on some more data regarding this topic, that the EPI associates with the incidence of high-grade prostate cancer. So those are results from a pooled analysis from more than 1,000 patients. And what you see is with an increasing EPI score, the high-grade prostate cancer risk also increases. And if you take a look at the numbers, you will realize that until values of 50 to 60, The value of the epi correlates as a rule by thumb with the relative risk of high-grade prostate cancer. So a epi score between 30 and 40 actually has a high-grade prostate cancer risk between 30 and 40. So that's a rule by thumb that is valid until values of 50 to 60. So this is another very interesting sheet because this is a sub-analysis of patients that do have a PSA of 4 to 6 and are between 60 and 70 years old. So those are very, very similar patients. However, if we separate them by the EPI score, you can see that there is a wide range of respective EPI scores, even though the clinical parameters that you are going to obtain in your daily clinical practice are very, very similar. So if we combine that with the validation cohort of the primary validation studies, you will see that there are patients that are below the cut point where biopsies can be avoided with high certainty, with a negative predictive value of 91.3%. So again, it has to be mentioned, this is a very, very narrow range of PSA values and age. So very similar patients at first sight, but very different regarding the EPI test. Let's go to the micro level. And those are actual cases, not made up, for patients that go to your office that have very similar PSA values. You see, range of PSA value is between 5.7 to 6.3. The ratio of free PSA is a little bit different. The PSA density is a little bit different as well, but still, it's hard to determine who to biopsy and who to just survey. However, if you combine the EPI test, the picture might become a little bit clearer. You see, there's a trend. Some patients have a very high EPI, and on the other hand, patient C and patient D, for instance, are below the cut point. So it's up to everyone's mind. What would you do with those patients? Would that be enough for you to refer from biopsy or to proceed with biopsy? But it just highlights the point that EPI can add something to the basic clinical parameters that we usually have in our daily routine practice. So let's dive a little bit into the data behind the ExoDx prostate test. It has been actually validated by robust clinical evidence. So there has been a prospective clinical validation studies that included 2 intended use patient populations that represented more than 1,000 patients from over 24 urology academic and community clinics in the United States, not in Europe. The validation study results were published in JAMA Oncology in 2016 and in European Urology in August 2018. So very well perceived high impact publications. And they ultimately demonstrated a 27% reduction in unnecessary prostate biopsies. In addition, the ExoDx test was able to discriminate between high-grade Gleason 7 or more and low-grade Gleason 6 prostate cancer, as well as benign disease. And the ExoDx test was associated with improved identification of patients with higher grade prostate cancer among men with elevated PSA levels, and ultimately was able to reduce the total number of unnecessary biopsies. So let's dive into the details of the JAMA Oncology validation study design. As mentioned earlier, patients who were 50 years or older and presented with an initial PSA value of 2 to 10 were included in either a training cohort or a validation cohort. The cohort representative of real patient population in the EPI validation studies showed a median PSA of 5 and a prostate cancer prevalence of 48%. So when we compare the area under the curve of those cohorts compared to PSA alone and other risk assessment calculators, in this case, the PCPT calculator and the ER-SPC calculator, you see that the area under the curve for the ExoDX test was actually higher. So the ExoDX outperformed PSA as well as clinical risk calculators for clinically significant prostate cancer. And it did that in an independent fashion. So when we take a look at the true positives and the false negatives, as well as the true negatives and the false negatives, we actually see a sensitivity of 92% and a negative predictive value of 91.3%. When you take a look at the details, you see that just 12 patients with a Gleason score of 7 and more were actually missed by the EPI test. And most of the false negatives were Gleason 3 plus 4, so Gleason 7A with a maximum number of 3 positive cores. So how does the EPI-CE European validation cohort compare to this data? You see that it's very, very similar. In the European cohort, we have a negative predictive value of 89%, and the sensitivity is actually pretty much equal, 92% in both cohorts. So very, very comparable results in this regard. So I've talked about primary biopsy, but we haven't really talked about rebiopsy. However, I have mentioned that the NCCN guidelines actually endorse the EPI testing for rebiopsy patients as well. And this is based on another study that has recently been published that analyzed the ExoDX results in patients with prior negative prostate biopsy. So the intended use population was a little bit more than 200 patients, and they all were referred to the urologist for repeat biopsy, as previously mentioned, prior negative prostate biopsy. So with the already established cut point of 15.6, we were able to observe a sensitivity of 82% with a negative predictive value of 92%, and ultimately were able to avoid 27% of unnecessary repeat biopsy. And only 1% of patients with a Gleason grade of 3 or more would have delayed detection. So let's talk about a little bit about the clinical utility. How can we implement the ExoDX test into the clinical algorithms that we use? There has been a study on this topic as well. It has been recently published in 2020, and this study was aiming to determine the clinical utility of the ExoDX prostate test in men presenting for initial biopsy with a PSA value of 2 up to 10. And the results were pretty interesting, a little bit surprising if you call it that way, because one of the main findings of that study was that the EPI test brought or increased patients' confidence and the compliance between the decision of the patient and the opinion of the treating physician was significantly higher if EPI was implemented in the clinical algorithm. And the performance in this real world setting was actually pretty good as well. Here we see the area under the curves for the respective validation studies. The first validation study that has been published in JAMA Oncology, the second validation that has been published in European Urology, and now on the right-hand side, we see the curves for the clinical utility study that has recently been published, and we do see very, very similar results. So one can conclude that the EPI test does work not only in a somewhat artificial validation setting, but also in a real world setting in the clinical utility study. What is lying ahead of us? What are future steps that we need to take? First of all, we have to integrate MP, MRI, and molecular biomarkers into one algorithm. And this has recently been done. This is just a very, very recent publication, just several weeks ago. And the authors showed several or analyzed several algorithms where they actually implemented different molecular biomarkers and MP, MRI into the decision-making process. And what they found was, this is just one of the proposed algorithms that is focused on the EPI test. What the authors did was they performed a liquid biomarker test, so in this case, EPI or the 4K test, and the biomarker test was followed by MP-MRI if the biomarker test was positive. And the patients were followed by biopsy if MP-MRI as well was positive. They skipped this mandatory thing for patients that had a EPI of 19. So it's important to mention that stratification. However, you see, this is a kind of neat algorithm that implements biomarkers as well as MP-MRI. And by doing this, they just missed 4.8 to 5.6 patients with ISOP grade of 2, so Gleason 7A or more. But by doing this, they were able to, or would be able to, avoid roughly 40% of the biopsies, and they were also, or would be able to avoid up to almost 40% of MP-MRIs. So very interesting results from a clinical point of view. Those results go hand in hand with the next future step, namely the integration of molecular biomarkers into clinical decision trees. And I've already showed you this slide, which was termed PSA screening 2.0. What if we propose PSA screening 3.0 by implementation of molecular biomarkers into the primary risk stratification before MP-MRI? Just as recently published by the colleagues in the Journal of Urology, as I showed you just before. So that would be something that should be thought of. And finally, we are, of course, eager to facilitate the at-home sample collections and therefore reduce in-clinic traffic. And especially nowadays, this is a very, very important issue. Let's summarize the talk. We have learned that the ExoDX EPI test is a non-DRE urine-based liquid biopsy genomic test to assess the risk of high-grade prostate cancer in men that are 50 years or older with a PSA level of 2 to 10 that are considered for initial or repeat prostate biopsy. There is strong and relevant clinical validation data and also clinical utility data that support the efficacy and the value for biopsy patients for ExoDX testing. And ultimately, the results from those multiple studies demonstrate that ExoDX can avoid roughly 30% or more of unnecessary prostate biopsies. So this is the end of my talk. I thank you very, very much for your attendance, and I'm looking forward for your questions. Thank you very much.
There are a couple of questions that come in already. Dr. Kretschmer, I hope you can answer. The first one here is where might this test fit into the EU guidelines for early detection of prostate cancer?
So thank you, Mikkel. Thank you for asking the first questions, and thank you everyone for participating, for actively participating in this webinar. And so the first question is already quite a challenging one. We have already talked about the proposal from the EU to the European Commission regarding the PSA screening 2.0, and we have talked about potential 3.0 screening, where we might find a role for molecular biomarkers in the pre-MRI risk stratification. So the proposal for the EU Commission was basically based on clinical risk assessment, such as parameters that are used in many clinical risk scores, such as DRE, such as family history, race, prostate volume, or PSA density, of course, total PSA, free PSA ratio. So those are parameters that most urologists are pretty familiar with and that are usually implied into the patient and physician risk assessment. So biomarkers maybe not so familiar yet, but they might have a significant role in this setting. They are already mentioned in the EAU guidelines, and there is a recommendation to use risk scores and to use imaging as well, but there is also a recommendation to use tissue or liquid based molecular biomarkers in the pre-biopsy risk assessment. So we will have to find a role for biomarkers in this setting, and this is something where they might fit quite well, in my opinion. The other thing is post-negative biopsy risk assessment. And that is something that is very interesting for sure as well. And we do have data for a couple of molecular biomarkers in this setting. There is still a debate ongoing, and there's still no strong recommendation to use one biomarker or to prioritize one biomarker over another. We do have to acknowledge the role that MRI plays and the role that has been highlighted in recent guideline updates. The role for biomarkers still not so clear, but there is a relevant proportion of patients who might benefit from those biomarkers. That is for sure. And yeah, it's our challenge to identify those patients and to implement biomarkers in this risk assessment in a shared decision making, in a smart way, and in a cost-effective way as well. So many challenges lying ahead of us, but there is a role, and there is just we need to define this role properly.
How is this test different from the PSA3 test?
So the PSA3 test is, at least in the region where I am located, is a very commonly used, or at least is the most commonly used biomarker test. So many urologists have heard about it, have used it as well. So they are quite familiar with the PSA3 test. Regarding the collection process, there are some major differences. The most obvious one being the fact that you don't need DRE or prostate massage whatsoever before collection of urine samples that are bound to undergo epi testing. So this is a main difference from a patient's perspective, that he doesn't have to go a thorough prostate massage before that. And the PSA, from a more scientific point of view, PSA3 is based on a clinical algorithm that is based on some other clinical parameters as well, in contrast to epi, which is based on a molecular signature that includes PSA3 as well, but also other relevant genes. And that is known to be associated with high-grade prostate cancer or clinically significant prostate cancer without in an independent manner, so without any clinical parameters. Yeah, so those are main differences that can be mentioned.
Okay, then there's another one here that says, can you explain again how to interpret the results above and below the cut point of 15.6 and what action should be taken?
Okay, so once the sample has been processed, you will receive a standard form sheet that I've already presented during the webinar presentation. And as correctly mentioned, it will show you a score. It's not binary. It will show you a score from the patient that can be below or above the cutoff point. The cutoff point basically tells us that if you are above the cutoff point, then you have an increased risk of harboring clinically significant prostate cancer. And the risk of having clinically significant prostate cancer increases with an increased EPI score. So in addition to analyze whether you are above or below the validated cutoff point, it's also very useful to take a look at the actual score. If you're below the cutoff point, then you have a decreased risk of having clinically significant prostate cancer. So after you have received this information, it's again up to you to discuss with the patient what to do with this information. Again, this information is based on large clinical trials, so there is a scientific base for that. And so you have very relevant information whether to proceed with the next step, whatever this next step might be. Might it be MRI, or might it be prostate biopsy, systematic prostate biopsy? So those are the steps. They are not mandatory, but they add very important clinical information in this often very challenging decision-making process, whether to go biopsy, whether to go MRI.
You mentioned that you thought there might be a role for this test in the negative MRI setting, and you also mentioned that during the talk that many untrained radiologists tend to classify patients PIRATES 3. Is there a role for this test as in the positive PIRATES 3 patients as well?
I don't think so. Absolutely. The interaction between molecular biomarkers and MRI will be a very interesting research topic, and we will receive more and more information how to handle those patients. I think it is very important if you read the recommendations of the guidelines with the more emergent role of the MP-MRI. It's very important to focus on the context. So here in Munich, for instance, we are in a very privileged situation that we have a lot of very experienced radiologists who are very focused on prostate cancer detection. So overall, I think that our results might be very valid or are valid most of the time, but this might be completely different in another region where radiologists are not that trained into the analysis of the MRI, which is kind of subjective after all. And yeah, as I mentioned in the talk, if you are less experienced, there is an increased tendency of going with PIRATES 3. So the patient comes back to you, got the MPMRI, and now he has an what is called unclear result. And those are very challenging cases. We tend to proceed with biopsies in PIRATES 3 if the patient is younger, for instance, if with higher PSA levels. But there is not so much data on out there on how to proceed with these patients. And molecular biomarkers would have a very beneficial role in this setting as well. But not just in this setting, also MRI negative, PIRATES 2, large prostate, but in high PSA or maybe increasing PSA, also very challenging case. Do we proceed with MPMRI or not? Patients who already underwent some kind of transurethral procedure, which is more and more common as well, TURP, or a laser enucleation, for instance. Those are patients that are very challenging to analyze during MPMRI, which may lead to maybe false negative, false positive results. So even in the era of increased usage of MPMRI, I think there is still a decent uncertainty, and this might be something that that biomarkers can have a very beneficial role in just in just helping in these clinical scenarios. Clinical scenarios that are often pretty difficult, and they there is just more information needed in so many cases.
Well, at least I'm just seeing the results from the polls that we had during your presentation. There was a couple of polls asked to the audience, and it seems at least we have some people amongst the audience who agree with the fact that this is a relevant topic. Here's one of them. Would you consider utilizing a liquid biomarker such as FPCE as a pre-biopsy risk assessment tool if the data is convincing? And there's 100% agreement.
Yeah, not really surprising to me, and I think the convincing data is very important. However, the clinical utility is also very important. It has to be easy to handle, and this is something that I, in my opinion, see as a very beneficial point in regarding the EPI test. It's very easy to handle. So the sample collection process is pretty straightforward, pretty easy. You don't have to think too much about do I collect it before prostate massage, after the prostate massage, how do I store the samples. With the tissue-based biomarkers, you might have to involve the pathologist as well. So it's pretty straightforward, and that is something that is for routine use of a biomarker from the utmost importance, because all schedules are packed. You might have the test results pretty fast. You might have the response pretty fast. Usually takes 2 to 3 days regarding the EPI, so you get the test results back very quickly, and also the shipping process and everything has to be very smooth, and that is something that has to be determined, and that is something that is very important to the respective treating physicians. And on another note, the sample collection is based on first catch urine. So that is something that I mentioned. So it's not the usual midstream urine that we are very familiar with, but also the collection of the first catch urine is pretty straightforward with the Colli-P devices that we are getting more and more familiar with, and that are very easy to use for the patient. And yeah, might not bother the patient too much, and are not too prone to, let's say, technical collection errors. And yeah. Another advantage, in my opinion, is the decentralization process that comes with the EPI IVD CE certification, so that more laboratories are actually certified to provide the testing. You're not that's not just one centralized lab that is mandatory for the certified analysis. So that's something that's definitely on the pro side as well. Regarding the clinical usability of the test, and that is something that's very important in my opinion. It must not be bothersome to the treating physician to use the test.
Right. That's actually already getting a little bit into the question here, where the question is, what's your typical use of liquid biomarkers in the early detection of prostate cancer? I think the point you just made, that it has to be easy to use, is an important one there.
Yeah. So valid data that I can rely on, and very straightforward collection and analysis process. I think that is something that needs to be considered.
Yeah, just to round out the poll questions we had, it seems like the audience all agree to the question whether there are men that undergo biopsy who have low risk of having clinically significant prostate cancer, and that additional tools are needed to better risk stratify. And there's an almost 100% agreement to that question as well. So I guess we're all attuned to the same story. And with that, I think we'll round out today's session. I will just end up by saying thank you very, very much, Dr. Kretschmar, for the presentation. Thank you to everybody who has been listening in, and just remind everybody to come see us. Exosome Diagnostics will be represented at EAU in July, and will also be at the DGU, which hopefully will be a real live in-person conference again in Stuttgart this year in September. So come see us there, or check out the website, exosomedx.com, and we're looking forward to hearing from you. Thank you very much.
Thank you, Mikkel. Thank you so much.